Hi there, I'm Josh Lumley. I am the Vice Chief Medical Officer for North Star Anesthesia, and we're going to spend the next minutes talking about organ donation. And again, as I've shared with my previous lectures, there will be some overlap with other lectures. Any topics that are hit multiple times over, do bear in mind that those are concepts that are very high yield and high value. I do not have any financial disclosures to make. So we're going to talk about basic organ transplantation data, donor and transplant data, renal transplantation. So let's share some of the data here. Which of the following celebrities is a transplant recipient? The answer is D, all of the above. All these folks have had transplants. So pretty good 5-year survival across all organ systems, greater than 80% for kidney, a little bit worse for intestines and lungs, somewhere around 40%. But still, overall, the survival rates with organ transplantation are quite good in the United States. The current wait list for organs in the United States exceeds D. 100,000 people are currently waiting for organ transplantation at this very moment in the U.S. So right in 2014, that list was over 120,000. For the first half of the year in 2014, there were 16,000 transplants that were done. So we would estimate then that there was over in 2014 somewhere way over 25,000. So every day, 21 people are going to die waiting for a transplant. What we've seen is that the numbers of organs transplanted has remained pretty steady for the last 10 years, but the number of patients waiting for transplants has increased each and every year. So overall, 124,000 people waiting. The vast majority of those are waiting for kidneys. Followed closely, well, not really closely, but followed by liver is the next one, and then heart. So in 1984, Congress established the National Organ Transplant Act, which was a nonprofit working under a federal contract, which sort of oversees transplantation in the United States. Now, what it set forth is that while there is a financial value associated with transplantations, we don't pay money for transplantation. So if you think back and suspend reality and think back to the summer of 2007 or 8, when gas prices were $4.50 to $5, there was a market demand for a limited resource. And that's basically what organ transplantation is. But the National Organ Transplant Act realized that this is not an economic resource, that this is a shared good that goes to patients, and therefore there is no payment for those transplants. So every citizen has access to a transplant. So there definitely is an alphabet soup associated with transplantations. DD, LD, SCD, ECD, DCD, DBD. So deceased donor versus living donor for the most part. So deceased donor is for all of our organs. Living donor, the vast majority of our living donor organs are going to be kidneys. You can give a segment of your liver. You can, in fact, give up your lung, but it's exquisitely unlikely you're going to do that. Standard criteria donors versus extended criteria donors. And then donation after cardiac death versus donation after brain death. Donation after brain death, all organs, everything still is remaining perfused. Donation after cardiac death, only applicable to kidney, liver, lungs, and pancreatic islet cells. Which of the following is not true regarding organ transplantation? Death is always certified after the donor procedure. Death has to be certified before the donor procedure. Donor after cardiac death grafts. So this is considered to be a great source of deceased donor organs. So the donor is not brain dead. We control withdrawal of life support. We have a limited period after life support is withdrawn that the patient is is dead without a heartbeat before we start to harvest those organs. So careful judgment of the procuring and transplanting surgeon, and you have to work expeditiously because the body is not cooled. So basically it says that DNR status and decision to withdraw support is made prior to this happening. Surgeons can't do anything to the patient for a full 5 minutes after death is confirmed. So therefore, those organs that are very sensitive to ischemia, i.e. the heart, etc., cannot be transplanted. Organ preservation depends primarily on core cooling, which is why there are certain organs with death after cardiac death that are not acceptable and cannot be used, because you do have a 5-minute period where the body is still technically warm and not immediately cooled, and therefore there are organs that sort of miss their metabolic window and are not eligible for transplantation. So as we've talked about earlier, there's been a relatively stable rate of deceased donors and a small decline, but somewhat stable, for living donors. So again, the number of patients needing transplants has increased, but the number of available organs has remained the same, or in fact slightly declined in the last years. So only 50% of people define themselves as donors, and what we think about, there are so many people that are waiting for an organ. The farther a patient gets along in their disease, they may in fact put themselves out of a window for eligibility for a transplant, meaning their underlying disease resulting in their pulmonary disease or liver disease or cardiac disease may in fact make their disease so significant that they are now ineligible for transplant. Really significant development of transplantation with the extension of the ESRD program in 1972 from Medicare, which allowed for, started to put a real cost associated to ESRD and started to look at the value of transplantation. So let's talk about that for a moment, renal transplantation. So lots of indications for renal transplant, glomerular diseases, diabetes, polycystic kidney disease, hypertension, renal vascular disease, any intratubular interstitial disease, kidney cancer, or a previous graft failure. So risk to the living donor, it's minimal actually. So it's pretty similar to a normal surgery, i.e. 3 in 10,000 morbidity mortality rates. Kidney is going to last a lot longer and be more viable if it comes from a living donor as opposed to a cadaveric donor. So what we see is significantly higher rates of survival with our living donor kidneys as opposed to our cadaveric kidneys. What is the cost of not donating? Well, it's dialysis. Dialysis on average costs in the mid-60,000s a year. Transplant surgery costs $75,000 a year. So you recoup those costs in about 18 months. What are the physiologic derangements that we see in our patients that have end-stage renal disease? So a lot of them are anemic. A lot of them have platelet dysfunction, pericarditis. They may have hypertension, decreased EF, glucose instability, and of course, as all of us know, we always order potassium. They are very prone to electrolyte abnormalities. So in the operating room, we want to work with our surgical colleagues and the operating room staff significantly on what type of immune suppression we're going to do. Why? Because it's exquisitely expensive and it's something that your transplant surgeon is going to control. We want to also think about our alternative medications that we're going to use, that being Lasix, mannitol, and then our paralytic, likely going to use cisatracurium. And what kind of IV access are you going to have? What kind of fluid? 0.9, normal saline. And then of course, most of these folks are going to have AV fistulas, which are going to knock out at least one upper extremity and make it ineligible for peripheral IV access, or worst case scenario, you need a arterial line. So the drugs that we'll use, oftentimes going to use that propofol. Muscle relaxant, we'll often use cisatracurium in this one. Narcotic, fentanyl, Dilaudid is appropriate, but do bear in mind that morphine has a prolonged duration of action due to some of its metabolites going through the kidney. And also remember the metabolites of Demerol, that in patients with end-stage renal disease, it can precipitate seizures. Maintenance, you can use Ativa, you can use inhalational. Also remember that vasopressors, you'd preferentially like to use some inotrope as opposed to a vasopressor, along with lots of fluid. You want to avoid those vasopressors after transplantation because you get vasoconstriction, which can affect the perfusion of the new kidney. Antibiotics, Ancef is most commonly there unless they have an allergy, So immune suppression, most commonly is going to be thymoglobulin. It was approved in '99. It helps a lot, but it's really, really expensive. So if you're going to mix it, we want to make sure that our surgical colleagues have approved it and ordered it. At least 2 large bore IVs, as we talked about. Beware of the AV fistula. We'd like to avoid the lower extremity on the same side as the transplant because the iliac on that transplanted side may be clamped. So if at all possible, avoid that. Oftentimes, it's just easiest to place an IJ after induction of anesthesia. You can flip rapid blood loss if you need to. You can correct that volume deficit due to the bore of the IV. And then you can also administer bicarb intra and postoperatively in any infusions that need to take place. So monitoring is pretty much straightforward. Typical pulse ox, temperature, EKG, blood pressure. If you've got a central line, you may want to use CVP. Volume is critical in these patients. So I would consider a esophageal Doppler or some other agent that is going to assess your stroke volume and your cardiac output. It doesn't need to be a PA catheter at all. If you need to use an A-line, use it, although most surgeons like to avoid any intravenous access in the arterial, in the arteries, and avoid a blood pressure cuff on the ipsilateral lower extremity. Glucose measurements consistently in those patients that are diabetic, and you're going to have frequent venous blood gases for assessing the arterial blood gas, the pH, as well as our bicarbonate. Think about these sorts of things with your induction of anesthesia. Do bear in mind that uremia does cause delayed gastric emptying. Sometimes you will do an IV induction. Of course, there'll be NPO. You don't necessarily need to use sucks, but if you do bear in mind that there's not some artificially elevated increase in potassium levels with its use, but you do need to check your potassium levels prior to dosing it. Long-acting muscle relaxants, becuronium, pancuronium, that are metabolized by the kidney are going to go longer. Rocuronium, if you use it in a heavy dose for induction of anesthesia, may in fact last longer as well. Maintain that baseline blood pressure in order to facilitate the adequate perfusion, and always make sure that we feel good where our fluid volume is, where our volume status is in that case. Bear in mind, fentanyl and Dilaudid are appropriate for dosing this for intraoperative opiates in these patients. Pretty dense reading here, but just bear in mind that morphine is metabolized into M3G and M6G, and it can be metabolized by the kidney. Do bear in mind that M6G can continue its effects, so morphine itself can have a prolonged duration of action. Lots of steroids, thymoglobulin, etc., which are going to be given to you by your surgical colleagues. You don't specifically need to know to dose them. You just need to be aware that there are immune suppressant drugs that need to be given to a patient during the case, and you'll want to be in close contact with your surgical colleagues as far as dosing those. Surgeon will, in fact, ask for heparin prior to the transplant. And then you will be required to give, or you'll want to give, mannitol and Lasix based on surgeon request. All of the following are reasons to administer mannitol in a renal transplant patient, except 3 months post-transplant, mannitol administered patients had better renal function. So mannitol is very effective at decreasing in postoperative ATN. and changing and helping to perfuse those kidneys. But it is important to note that if you just use mannitol with IV hydration versus straightforward hydration, there was no difference in kidney function 3 months after transplant. Reperfusion syndrome, you're going to see this a lot in this discussion today, that once you reperfuse an organ, there is the possibility of hypotension. So you want to have adequate fluids available. You want to have inotropes and vasoactive agents available to avoid decreased preload and significant hypotension. Fluid management, in these sorts of patients, they're going to get a lot of 0.9 normal saline prior to reperfusion. So in this case here, you don't really know where you're at in terms of volume. Do you have enough? Are you just right? Are you overfilled? This would be a time to consider the use of an esophageal Doppler or some other agent to measure your volume status. Blood loss is rare, but you can give it if you need it. Urine. This one here is you and the nursing staff are going to frequently monitor urine output in those 5 minutes, 10 minutes, and 15 minutes after transplantation and reperfusion of the kidney. So a non-cadaveric donor, so a living allograft, will actually really have robust urine output very early on after transplantation. Cadaverics may be scant, it may be good, it just sort of depends, and the surgeon will probably evaluate that over days. Obviously, going back to the need for volume, you don't know if you've given too little, you don't know if you're just right, you don't know if you're too much. So too much, you get CHF, you get pulmonary edema. Too little, you risk underperfusion of the graft. So you really need to assess and be in touch with your surgical colleagues as far as what our volume status is, and consider using the Doppler. Contraindications to renal dilation after cardiac death include F, acute tubular necrosis.